Hello, and welcome to the Clinical Care Options Oncology podcast. I'm your host, Brian Topping. Today's episode features an expert discussion focused on optimal dosing strategies with Regorafenib and TAS-102 for patients with metastatic colorectal cancer. This episode is part of a larger program consisting of a podcast series focused on later-line treatment options for patients with colorectal cancer. During this podcast, Dr. Kanwal Raghav from the University of Texas MD Anderson Cancer Center in Houston, Texas, and Dr. Rachel Riechelmann from the AC Camargo Cancer Center in Sao Paulo, Brazil, discuss individualization of treatment, as well as clinical data and experience informing optimal dosing with Regorafenib and TAS-102 for patients with metastatic colorectal cancer. Please visit the show notes for this episode for a link to the complete program, including downloadable slide sets and additional coming expert podcasts. Now let's get started and hear what Dr. Raghav and Dr. Riechelmann have to say on this important topic.
Hello, my name is Kanwal Raghav. I'm one of the GI medical oncologists and associate professor here at University of Texas MD Anderson Cancer Center, with clinical and research interest in colorectal cancer. And I'm joined today to discuss third line and salvage therapy options in metastatic colorectal cancer with Dr. Rachel Riechelmann from Sao Paulo, Brazil. Rachel?
Hello, everyone. Hi, Raghav. I'm Dr. Rachel Riechelmann. I'm a medical oncologist currently working in Brazil. I am head of department at AC Camargo Cancer Center, and I also serve as the president of the Gastrointestinal Tumors Group in Brazil. My interests are in colorectal cancer, specifically in research, and as for patient care, I do the whole GI cancers.
Rachel, as far as patients with colorectal cancer is concerned, the last few years have been very exciting, right? We've developed, newer and novel therapies, I would say, at least for some targeted subsets, like, the BRAF mutation subset, HER2, MSI, maybe a few NTRK fusions if they are available. But there is a large group of patients. I mean, these are still small subsets, but there's such a large group of patients that still don't have other third line options, like targeted options beyond the current standard of care, which we'll discuss today. But I just wanted to see, beyond the patients getting first and second line chemotherapy, what are your thoughts on this, on the advancement we've made in these subsets, and what do you usually do for third line options when patients don't have these actionable mutations?
You are very right, Raghav. I mean, although this is very interesting to have these new agents and in rarely found molecular alterations, most patients do not have any molecular alterations that can guide targeted therapy in colorectal cancer. So for third line options, usually what we have based on level 1 evidence is Regorafenib, based on a phase 3 trial placebo-controlled study called Colorectal. And when we have the TAS-102, which is also a phase 3 placebo-controlled trial of TAS-102, which is an oral chemotherapy of fluoropyrimidine used in third or fourth line setting. So in my practice, what I tend to do is if patient needs a high response rate and had a good experience in first line with an anti-GFR, if they have a RAS and BRAF wild type tumor, we tend to re-challenge the patient with the same strategy. Or if the patient also needs response rate and had a good response initially to oxaliplatin-based regimens, I tend to re-challenge the patient with FOLFOX or KPOX. But if the patient, which is mostly the majority that don't really need a high response rate at that point, a cytostatic agent that would prolong survival and preserve quality of life is the aim, then I tend to offer either Regorafenib or TAS-102 for them.
Right. So, Rachel, one of the questions that, and also I think a clinical dilemma that comes up is when you look at the correct trial and the recourse trial, they were almost designed the same way, right? Like exactly. Randomization between placebo, Regorafenib, TAS-102, The only major difference that at least I can see is because regorafenib was already approved, the TAS-102 RECOURSE study actually had some patients that were previously treated with regorafenib. But otherwise, the trials were designed pretty much the same way. The population and eligibility criteria were the same. So when it comes to actually using this, what are the guiding principles that you use to actually, decide between REGO or TAS-102, if those were the two options?
Well, this is a very good question. And the right answer, we don't have it. I mean, we don't have a head-to-head comparison. But in my practice, I tend to evaluate previous toxicities of previous lines. So let's say if a patient has continuous myelosuppression, I tend to avoid chemotherapy, another chemotherapy, and then I go for regorafenib. Or on the converse, if the patient has an uncontrolled blood pressure, for example, I tend to go for TAS-102 instead of regorafenib because this agent can worsen blood pressure. But in the end, I think, at least in my practice in Brazil, we are much more used to offer regorafenib because TAS-102 was recently approved in about, let's say, 6 months. So most of the oncologists have more experience with regorafenib. But I would say that toxicities of previous lines of therapy and patient profiles based on comorbidities, this is what I use to decide. And also patients' performance status. So patients with ECOG 0 or 1 are more fit to receive regorafenib. If I have a more fragile patient, probably I would go for TAS-102 first, given that this agent has a more gentle adverse event profile. But what do you do?
Yeah, I mean, I totally agree with you. I mean, these are, some of the common things, like if bone marrow toxicity is an issue, TAS-102 is really not on the table. With regorafenib per se, if liver functions are a little bit poor from prior chemotherapy exposure, that's a little bit harder on patients therein. But one of the criteria that I also use is, changing sort of the mechanism of action of treatment. Because in most cases, these patients are usually either first line or second line patients that have undergone 2 years of chemotherapy. And most of the times that chemotherapy involves 5-FU in general, right? Like whether it is first line maintenance and then second line. So 5-FU we use continuously and almost throughout. And in those cases, I always feel this concept of giving a little bit of a chemotherapy free interval maybe have some effect on like subsequent, treatment options, very similar to what we do for chemo re-challenges, right? And TAS-102 mostly has a cytotoxic chemo kind of effect, whereas regorafenib, at least has some VEGF inhibition. And the reason why I think some of these times it's important is because there's such good data on continuation of anti-VEGF therapy in colorectal cancer. It always keeps on benefiting you. So that's one of the reasons. And the second reason is, if you look at the RECOURSE trial, it is very clear that whether you treat patients with regorafenib or not prior, the efficacy of TAS-102 was not really compromised, right? Yeah, so that's why we've been following that sequence, only because we just don't have that reverse kind of data. But this kind of brings me to next important question: is toxicity was one of the concerns that you laid forward, especially with PS. What is your dosing strategy when it comes to regorafenib? And then what is your dosing strategy when it comes to TAS-102?
Well, for regorafenib, I think the redose trial data came in handy because this is something that we were already doing it. So in the redose, patients were randomized to standard dose regorafenib or escalation dose. So the first week, patients received 2 pills, so 80 milligrams. The second week, 3 pills, 120. And then the third week, then patients received the full dose of 160 milligrams, 4 pills a day, and then followed by 1 week rest, compared to 160 3 weeks out of 4 weeks. So I think, it makes so much easier for patients to tolerate and so much easier for us to manage. And that I don't see the adverse events profile that I used to when I was using the 160. So it's so much easier now. And even when I compare the redose strategy with TAS-102, I cannot say that it's so harder to use regorafenib in that situation. So it's just easier. Patients tolerate well. They can take the drug longer. Exactly what was shown. The redose, we have more patients going beyond the 2 months CT scan evaluation. How do you dose? Do you dose escalate all your Rego patients?
Yeah. So, unfortunately, I think, there's no way of fine tuning the TAS-102 dose at least, right? Because you start with the standard dose and then, you look at the toxicities, and usually it's anemia or leukopenia that forces your hand in reducing those doses. And, you can make 2 or 3 dose reductions in TAS-102. But I totally agree with you. I think, for us here at MD Anderson, our standard has always been, even before redose data came out, we were doing some escalation because it's just such a good strategy because you're weeding out players that would just not tolerate that drug. And, I don't know what your clinical experience has been, but I've almost noticed that there are 2 kinds of populations that there are, right? Like people who would tolerate this drug and will not have any major problems. And then people who, even with lower doses of this drug, can have some trouble, right? The only way to figure that out is dose escalation. So what we do is we do weekly escalation starting with 80 milligrams, going all the way to 160 milligrams as tolerated. And now I think redose data has also allowed other people to do it because convincingly it has shown at least there is no detrimental effect to the outcomes that you're thinking about, right? Like overall survival, because that's almost the opposite, right? Exactly. Including the fact, which I think is underestimated in that data, is the subsequent lines of therapy, right? And actually people in the escalation dose were able to get more subsequent lines of therapy than the people in the standard dose, right? Because I'm presuming that they sometimes get deconditioned if you give them higher doses and they get, toxicities. So yeah, absolutely. Redose is the way for regorafenib, and we do that routinely.
And in my patients, most of the time, their best dose is 120. So most of the time, although in the first cycle, we tend to escalate to 160, usually 120 is the best tolerated dose. And that's what I continue from cycle 2 on. What is your experience?
Yeah, I think most patients will be at 120 milligram dose. There are a few patients that can go up to 160. More than the hand-foot skin reactions, I've noticed that anorexia, weight changes can also sometimes be dose limiting. This is one of the questions that comes to my mind. Like when you look at the grade 3-4 side effects for TAS-102 and regorafenib, they're very comparable in the recourse and the correct study. They're just different toxicities, but they're very comparable. One of the things that I have seen is patients going through chemotherapy, and then they really require transfusions and growth factor support when they go on to TAS-102. Has that been your experience, or what do you do in these situations?
No, I haven't seen that much. Well, I've been using TAS-102 for the last 6 months only, so I don't have a huge experience. I have seen mostly neutropenia, anemia, but not at the point of blood transfusion. No.
So Rachel, I think we're coming towards the end of this. Any final thoughts or clinical tricks of which you would like people to know about how to treat these patients in third-line setting?
Just one thing that I often do with patients receiving regorafenib is that when patients develop some adverse events that you really need to stop the drug, so let's say hand-foot skin reaction or a skin rash, I usually don't do like we do in clinical trials. I don't wait for the whole week. I just wait a few days. If patients are better, then I try to re-expose or restart the drug again, because I think that for the VEGF blockade, the continuous blockade is important. Because if you just keep, 1 week on, 1 week off, then I think I have the perception that these patients do worse. They tend to progress earlier. Do you have the same impression?
Yeah, I think the only opinion that I would give on this is, first, we should always think about clinical trials for these patients because, even though these drugs are effective and supported by good evidence, we want to improve these outcomes. But more importantly, just like you said, watching patients carefully and following them closely is very critical. Like these are not the kind of drugs you give to a patient and then see them back in a month. This is something that you need to follow up, whether it is a telephone call or a video visit or just every 2 weeks. But we watch patients very carefully during this setting because they're already like frail, and then toxicities can sometimes do that. And the earlier you recognize it, the easier it is to manage it in the long term.
I agree.
So, well, Rach, thank you very much for joining me on this discussion. It was really cool, and I hope that this would be of value to the listeners.
Thank you, Dr. Raghav. Good to see you and hear you, and I also hope that it will be useful for the people who are listening. Bye-bye.
Thank you very much, Dr. Raghav and Dr. Riechelmann, and thanks to you, the listeners, for joining us. As a reminder, to view the full program and to download the slide set associated with this discussion from the Clinical Care Options website, please click on the link in the show notes. As always, thanks for listening.